Hi, this is Bejoy Thomas again. Welcome back to my channel 5 Minutes Neuroimaging with Bejoy Thomas. In the last three episodes, we discussed about cerebellar development, hypoplasia, and atrophy, as well as some brainstem anatomy. We also discussed about the embryological basis of different medulloblastoma subtypes. In order to clarify some of our doubts and discuss further about the embryology, we have Dr. Sniya Valsa Sudhakar, consultant pediatric neuroradiologist from the Great Ormond Street Hospital, London, UK today.
Hello everyone, this is Sniya here. Thank you Bejoy for this platform and opportunity. So let's start. Today we'll look at cerebellar hypoplasia and atrophy in some detail and clarify those concepts. And we can also see an interesting case of embryology pathology correlation. So we will clarify these concepts through four scenarios. One is hypoplasia versus atrophy. And let's get into that. So these are T1 sagittal images at very young age. One is 11 days of age and the another one is 11 months of age. You can see that this vermis is not tall enough. It does not reach the intercollicular line or the orbix. But there is no separation of the folia. So this is your classic hypoplasia. Whereas on this case, the cerebellum is really well formed, but for 11 months of age, you can see the foliae are quite separated, the fissure is widened. So this is what we would call an atrophy. So what happens when you image it later? So this child at 4 years, the imaging appearances are largely stable. It does not go on to develop something like atrophy. It remains stable in appearance. So this is cerebellar hypoplasia with a small sized cerebellum because the cerebellum did not reach its full growth potential. Posterior fossa, as we know, can be either small or normal in size, and the appearances are stable over time. For atrophy, when you image them later, you can see that the atrophy progresses, and here again the overall volume has been reduced and the foliae are more wider apart and the fissure is also wider compared to the initial scan. This was a case of INAD, as you can see from this claval hypertrophy. So cerebellar atrophy happens in a normally developed cerebellum in this case and will progress over time. So that is the difference between hypoplasia and atrophy. It's important to differentiate because they initiate two different pathways of investigation, because one is developmental and the other one is degenerative. Let us look at two more scenarios. So here at 11 days of age, that looks like a hypoplasia because it does not reach the superior aspect and there isn't much of interfolial separation or fissural widening. But what happens at 11 years? So now it looks like a significantly atrophic cerebellum. So it looks like hypoplasia to start with and progresses to have a atrophy-like morphology. So how does this happen? This is because of the prenatal onset of degenerative disorders. So because it is prenatal, the cerebellum is never allowed to reach its full growth potential. So it looks like hypoplasia to start with. But these are intrinsically degenerative disorders. So atrophy ensues over time and progresses. PCH and CDG are two classic examples of the spectrum. Let's move on to the fourth scenario. So the fourth scenario is a 4-year-old with a T1 coronal showing significant atrophy of the cerebellum. What do we expect at 12 years? We expect it to progress. However, on the MRI, you can see that it has hardly progressed. It remains almost static. So this is atrophy, which does not show any progression over time. So this is the non-progressive cerebellar ataxia clinically, or atrophy as the imaging correlate, which shows stable appearances over time but looks like atrophy at all points of time. These are usually due to increased apoptosis that happens during the cerebellar development and has a host of genetic causes underlying this appearance. And this list is actually increasing. So we looked at 4 different scenarios, and I hope this cerebellar atrophy versus hypoplasia is clear now. And the third scenario, although confusing initially, it's just that it is actually a degenerative process which starts early, so gives rise to both hypoplasia and atrophy. and this one is a non-progressive pattern of atrophy. But as probably was very clear from the illustrations, we know that this differentiation is not really easy on a single scan in many cases, and follow-up imaging is the key. Let's move on to the case. So this was a child whose fetal ultrasound showed a dysplasia of the cerebellum. So he went on to have an early MRI at 6 weeks of age. So what does the MR show? It shows significant asymmetry of the cerebellar hemispheres. As you can see, the left cerebellar hemisphere is not only small, but also quite irregular. There was no other supratentorial findings. And at this point, the diagnosis was hypodysgenesis of the left cerebellar hemisphere. And given the asymmetry, we would think of a prenatal insult like a clastic cause. Let's see what happens later. So this is the MRI at 10 months of age. So now the left cerebellar hemisphere, which was dysplastic, is completely replaced by a heterogeneous enhancing lesion, which is also quite cellular, as evidenced by this diffusion, and shows this brain within brain kind of appearance. And as expected, this was a medulloblastoma of extreme nodularity, which we know is always SHH driven. So what is the connection? So if you look at the cerebellar development, we know that the Purkinje layer cells secrete the SHH, which is really vital for the proliferation of the external granular layer. And external granular layer is what is similar to a germinal matrix of cerebellum. And once the proliferation finishes, they actually migrate again internally and forms the internal granular layer. So it is not difficult to imagine if this pathway is interrupted to have a really small and irregular looking cerebellum. And we also know that further mutations in the SHH pathway can cause this SHH driven medulloblastomas, which are hemispheric, and all the MBENs are usually SHH driven. So this, I thought, really beautifully that it illustrates this connection between embryology and pathology. That's all for today. Thank you so much for your attention. And if you ever wanted to get in touch, this is my email. Once again, thank you, Bejoy, and all the very best for your YouTube channel.
Ladies and gentlemen, that was Dr. Sniya Valsa Sudhakar talking to us. Thank you so much, Sniya, and wait for the next video, 5 minutes neuroimaging with Bejoy Thomas. Thank you very much.